Moving on, my goals for this evening are there'll be no penalties, but it will be to explain the service that I provide and to provide your patients, to understand the challenges that we face in treating musculoskeletal disorders, the common conditions that we see, and also how to diagnose those conditions. We'll look at examination techniques and the investigations that we use. And then at the end, depending on time and your feedback, we can do some cases. A little bit depending on time. So, a little bit about me. I work in Tunbridge Wells Hospital. I was appointed there about 4 years ago. Time has passed massively, but where I started, I initially did my training in London at St George's, and then I followed my wife, who's a GP, and she was a year ahead of me, so I ended up following her. And so she moved to Oxford, so I moved to Oxford, and I did the Oxford rotation between Oxford and Reading. I then, during that time, I worked at the university, and I got a scholarship at the university, and I followed my kind of my real desire, which was to understand the shoulder, and I did a thesis in tendon failure with a place called the Botner Research Centre, which creates 35% of the orthopaedic research in our country. It's a huge amount for a small unit at Oxford University. And so I worked with them, and I created, I did several projects, and my projects ended up turning to papers, and those papers ended up allowing me to submit for the International Shoulder Award, which is a Didier Pat, presented by the European Shoulder and Elbow Society, and I won that, and that's helped my career by putting me on the map. And you know, and it's also the whole experience has helped me to really formulate, you know, my interest, which is in tendons. During that time, I also headed off to Brisbane for a year to put Aussies back together again. In Australia, you see very much an image that's presented to you of Australia, which is of, you know, calm and you know, sun, everyone taking it easy. But it's a fairly violent race. They crash their cars all over. I put so many Aussies back together again. I used to do replants, everything. So that's kind of helped form the reason why I can do everything. You know, I operate on everything in the arm because of that training I've had in Australia. Because that's the way they are. They don't do. There's not a hand surgeon. There's not a shoulder surgeon. There's a surgeon that covers everything, including plastics. So when I was there, I think I replanted about 20 fingers, which, you know, in the UK, in orthopaedics, you just never do. So that's a little bit about me. The service I provide, I'm based at Tunbridge Wells. I cover the whole of the upper limb. I do peripheral clinics, which may be close to you, which is Edenbridge, Crowborough and Sevenoaks. I also do my main clinics in Tunbridge Wells. So that's a fracture clinic, being an orthopaedic surgeon, and pretty much a general upper limb clinic. So, I don't know, most of you it's osteopathy and physios, but in medical school, the bane of an orthopaedic surgeon's life is the fact that people look down on you. Oh, orthopaedics. Oh, you know, kind of, you know, it's all brute, no brain. And so we are the butt of the jokes. And this continued until there was a BMJ article about 4 years ago where they did IQ tests. And they found that the orthopaedic surgeon had a higher IQ on average than the anaesthetists, and which upset the anaesthetist no end, and the banter stopped. So you know, it is a fairly cerebral profession. It's just not about just using your hammer and hitting nails and, you know, screwing metalwork in. And so the idea that orthopaedics is simple is because you get to think it's broken, so why don't we fix it? It's torn, so therefore we should repair it. It's worn down, so simple, let's just replace it. But it's not that simple, because the problem is pathology is not always related to function. And what that means is that, you know, in this chap here, the shoulder on the left is actually his pathological arm, which has got a massive rotator cuff tear, and on the right, he's only got a small partial thickness tear. because pain's driving it. So that's the bizarre thing, that pathology, people can have pathology and have no pain from it. And that's probably one of the fundamental issues we have in musculoskeletal medicine, that we just don't understand why somebody can have so little pain and dysfunction and yet have so much pathology. I see so many people where they come in and they say, I've had symptoms for a month. You look at their shoulder on an x-ray and it's worn down. This is arthritis that's gone on for 10 years. But they had a fine shoulder. It worked for them. And so that's a really fundamental issue that we're looking at, particularly in osteopathy and physiotherapy, that you see these guys. I don't. I see them at the end. But the pathology's there, but actually they function really well. And often with simple treatment, they can do really well. The second dilemma we have is that pathology doesn't always cause pain. So this is a classic picture of a chap with a Popeye lesion, which you might see. If you went to a changing room and looked at 65-year-old blokes, you'll find that lots of them have Popeye lesions, and they don't even know they've had it. So they can have a pathology and yet have no pain from it. And so that then creates a difficulty diagnostically. What do you treat? Because suddenly in the asymptomatic population there's all this pathology that is asymptomatic. And so therefore, the issue is we have a curse. And the curse is the MRI report. Because as soon as you image somebody, you don't get a, yeah, it's normal, over 40. If you imaged me and I was, I had my neck or my shoulder, it's never coming back normal. It comes back as a list of things. And you read it, and certainly for a lot of the GPs, or I don't know how your access to MRI, it's really difficult to interpret what is going on. Okay, if you put a 16-year-old through an MRI, you probably will get a normal. But certainly if you put a 40 or 50-year-old, you'll get reams and reams. So there's a lot that can go wrong that isn't normal, but does it cause you symptoms? And the problem we have is that we create a difficulty where if you start to investigate people with imaging, you can find things that aren't the problem. Because you can take 100 people off the street and find the same problem. So it's linking the pathology with the pain. And that's probably, if we could solve anything in orthopaedics, it would be to work out why some people get pain with certain pathologies. We just don't know. We know there's a genetic element. So if you had a rotator cuff tear and you were symptomatic and you had a twin, it's likely they'll have the same. If you have a rotator cuff tear without symptoms and you're twin, it's likely the twin won't have symptoms. So there's a genetic element to pain and pathology, but we don't understand why. And therefore, the difficulty is this is all in the mix. And you see that. You must see that in non-operative, that you see somebody and suddenly you may ask the GP to get an MRI or an X-ray and it comes back as something, ooh, what's that? I didn't expect that. The question is that the cause of the pain? And so often diagnostically, that's the real challenge, and why the MRI, asking people to have an MRI can be a good thing and a bad thing. And that's where we are. Because often GPs, I see patients where they've seen an osteopath or a physio, they've had treatment, and they say, oh well, you need an MRI. But the MRI, it's what you do with that MRI, and it's how you interpret it, because you can easily go off on a tangent. So there's lots of things. So what I was hoping to do today is maybe go through a few of the words you might see in an MRI. And hopefully by the end of this you kind of understand a little bit of consequences. Some of those consequences is age-related. Something, in a 60-year-old, if they have a Bankart lesion, is that important? If in a 60-year-old you had a slap tear, would a low-volume joint, on an MRI cause you problems? So there's lots of, these are just some of the interpretations from the shoulder. And so going through them, if you see the MRI, chondral full thickness loss. Does anyone know what would that indicate? That's what's written. These are all words that are taken from an MRI. But chondral full thickness loss, is usually
Bone
on bone arthritis. They don't write that. They don't say this patient's got arthritis. They say condylar full thickness loss. Slap tears. Now slap tears I'll talk about a little bit later. Rim rent tear. A rim rent tear is where the tendon has, it was attached, with a full thickness, and what it's done is it's lifted off, and so it's what they call a rim rent. It's still attached. It's a partial thickness tear. You see that in the asymptomatic population. Paralabral cyst. That is where you get cysts around the socket, and so they can create fluid. They can be asymptomatic. Like most things, cysts can not be the cause of the problem. So it's usually linking the symptoms with the cyst. Bankart lesions. We'll come to Bankart lesions in the next bit. The great news is if you get no internal derangement. Does that mean everything's fine? Hey, there's nothing wrong with this patient. But I'll come to this sometimes when it either is, and that an MRI and X-ray is going to be normal, and that's the expectation. Tendinopathies we'll come to. Reverse heel sacs is where when you dislocate and you pop your shoulder out, what happens is the ball comes out and then it hits against the rim, okay? And it makes a dent. And a heel sacs lesion is just the dent. And reverse is if it's on the wrong way. So if you come out posteriorly, a heel sacs lesion is if it comes out the front, which is 95% of them. A reverse heel sacs is where it comes out the back and makes a dent on the socket. And so it's a dent in the ball from hitting the socket. Low volume joint is something that you may see with frozen shoulder. And bursal-sided partial thickness tears is impingement. But some of those we'll come back to, so don't worry too much. But probably my top tip of the evening, and I say this to surgeons, GPs, you guys, if there's no or little pain or functional limitation and it won't kill you, leave it alone. I see lots of people where the only thing I can do as a surgeon is get people out of pain and improve their function. If they have no pain or minimal pain and they're functioning well and it won't kill them, leave it alone. There's nothing I can do that will help them 5 years down the line. I treat their symptoms now. There's nothing we do in surgery, orthopaedic surgery, which is prophylactic as such, unless you're talking cancer. The rest of it you are treating today. If they haven't had symptoms for 6 months or 2 months and everything's working, you can only take on the risks. I talk to people about a risks benefit. If the risks and benefit are far apart, great, we go ahead with the surgery. As soon as that area narrows, then you have to question whether you're prepared to go ahead. And we are in a culture where people are demanding more and more surgery. They don't think they can get better any other way. They see this is a magical event that's going to happen to them. And they also have issues where they're not engaged, where we're now looking at activation. Patients that are activated, when they come to see you, they're not going to say, yeah, what are you going to do for me? They're going to talk about what we can do together. And you must see that in osteopathy. You know those patients. There's patients where we constantly demand, what are you going to do? What are you going to do? Yeah, this is what you can do next. That they are patients that won't get better, whoever they see. We need to find, we need to activate. It works together. Surgery, whatever I do, only works 50%. The other 50% comes from the osteopath and the physiotherapist. That's the principle. Because we'll come to later that the shoulder it's just muscle. It's just kind of muscles holding on the arm. So I can fix everything, but unless they can retrain their arm and work, regain normality, they're never going to get better. So how do I work? Well, the first thing is obviously getting a diagnosis. Now I know within your field and osteopathy and physio, sometimes you can't make an absolute diagnosis. I can't, generally I'll see people in clinic and I see so many shoulder, elbows, and I get used to it. And so I'll say, well, that person, yep, I've seen that before, okay, they've got no symptoms, they've got pain, but you just get a sense that's going to be a frozen shoulder. No one can absolutely diagnose it, but you just get a sense that's going to be a frozen shoulder. The level of pain, what they're describing, what's happened, that helps me to gather that. And I say, I can't diagnose it now, but next month when the stiffness starts, I think you've got a frozen shoulder. So the history is really important when it comes to diagnosis, taking what the patient exactly says. Then we have the examination. Then I use injections to help me to target the pain. The problem is, going back to the original problems with pathology and no pain, is targeting where the pain comes from. Is it the neck? Is it the shoulder? Is it coming up from the wrist? So being able to target it, once I think I know where the pain is, I'll do diagnostic injections. What they are is local anaesthetic. I'll put local anaesthetic where I think their pain is, and I'll ask them to keep a pain diary. And then, if I get rid of the pain in the first 2 days, that's the local anaesthetic, I've hit the spot. I mix it in with steroid. That steroid is there to give them a therapeutic benefit. A common error is that people say, oh yeah, you've hit the spot. Yeah, it got better about 4 or 5 days in, it was perfect. But it's not that. It's, the steroid will work its way around. We know that because there was a study from the BMJ which showed that whether you inject the shoulder or the bottom, they get benefit. Because the steroid, it starts locally, but it works its way around. Diagnosis is from the local anaesthetic. So it's in the first day. Did I hit the spot? I ask them often to stay out, wait for an hour in clinic. Does it feel better? Has that pain gone? How much has gone? And that's what we use for our pain diary. Imaging, I use a screening, which is X-ray. But the only time I get MRI is often pre-op. So what I want to do is, I know what's wrong with you. I just want to quantify it. If I see somebody where their clinical presentation does not fit the MRI, and the MRI comes back as something different, generally I'll ignore the MRI because it's not the pathology. Because, as I said, asymptomatic patients can have lots of this pathology and have absolutely normal shoulders. So the imaging I use is very much, once I know what's wrong, to quantify it and to target surgery. So I don't use imaging as a diagnostic tool. Otherwise, I'd get it wrong about 50% of the time. So one of the things people often ask me is, what is the key thing in shoulders that determines what the diagnosis is? And the key thing in shoulders that determines the diagnosis is when they walk in by their age. Pathology is very age-based in shoulders. The young get certain pathology that they don't get in the old, and vice versa. So when you see a patient walking into your room, pathology you should be thinking, there's 3 things that's likely to be the cause of this. And then you can work. And you get it right 99% of the time. So age is really important. Now, you might wonder why I've got 3 humans there, and then I've got Grandpa Simpson. And I've used this slide for about 3 to 4 years. And the problem is whoever goes there never makes it beyond about a year or 2. So I've had Brucey, and I've had one of the Ronnies. And so now, having had that kind of success rate with my photo, I put down Grandpa Simpson, and then I heard that the Simpsons is over. So I'm going to have to change him. So yeah, Simpsons is coming to an end. So it's a doom being on that slide for the older gentleman. So in the very young, what young people get is instability, of the shoulder. And what instability is, it's often in 2 forms. So in the first form, you get type 1 instability, which is what we call traumatic. And that's your rugby player. And so many of the England team, had dislocations. And rugby's a real classic. You can get it in any sport. Football, but rugby's a real classic. And what happens is what makes your shoulder stable? Well, what people have is, I'll use my English computer, this is their ligament underneath. That's the inferior glenohumeral ligament. And what that does is it acts as a sling, as a hammock. And you can see the bloke over there in the hammock. He's sitting there happily with 4 attachments. You can sit in your hammock. And the problem is if one of those attachments, so if one cord from your hammock breaks, you'll fall out of your hammock. And that's exactly the same as the rugby player, that the ball will fall forward. And so what rugby players and traumatic instabilities, where they have an incident, they tear the shoulder, they injure the shoulder, doesn't always have to come out. Sometimes they just can't play on, and then they go back about 2 or 3 weeks later and they struggle. And that's what a Bankart lesion is. So a Bankart lesion is where you tear off the front of the ligament. And that can be a bony Bankart or just a Bankart, which is soft tissue. But it's that Bankart lesion that means that you fall out of the sling, of the hammock. And that's what causes people to dislocate. Now, in the younger age group, so you also get the opposite, which is type 2 instability. And these are the stretchy people. And you probably see lots of stretchy people, but they're classically the young girls who, they're great at gymnastics, because being stretchy and gymnastics goes together. And so these are patients where they often start where there's no history of trauma. They might be a minor, but there's no significant. And what happens is they start to get pain. They start to use the shoulder and it aches. And then it gets worse. And then they start to kind of make some abnormal movements. They move their scapula abnormally in an effort to position their shoulder. And these are the young people where they can, at the extreme, be all over the place, where they can't lift the shoulder because they've forgotten how to. And it's because they've lost the stability that the ligaments would normally confer, and they haven't got the muscle toe to be able to confer secondary stability. But it's just stretched and it moves. And sometimes they can pop in and out themselves. And we see people in A&E who do pop it in and out themselves because they like the attention. We see other people who actually, they start popping it in and out themselves at parties, and then suddenly they lose control, and then it pops out when they don't want it to pop out. And these are a very difficult bunch of people. But that's the difference between a type 1 instability and a type 2. So you have traumatic, and then we have atraumatic instability. And we treat them very differently. So the pathoanatomy of instability, so for a type 1, they can get this thing called a Bankart lesion. Now the Bankart lesion is, as you see, so what you're seeing on the socket there is kind of, you've got bone, and then the socket gets deepened by labrum all the way around it. And that labrum has ligaments attached. And what happens is, on that ligament here, the ligament pulls, and it tears the labrum, and it tears that part of the hammock. And so, therefore, the ball is no longer supported by the hammock, and it wants to fall forward. And we see that on an MRI. So, here, so this is the tear, so you can see it in here. And, it looks innocuous. You think, does it look too dissimilar to the other side? But actually that tearing suddenly means that you lose tension in the ligament, and that's why they fall forward. And this is an MR arthrogram. I'll talk about this. This is why, if you've got a plain MRI, you might not see that, because a plain MRI struggle to distinguish here, and because an MRI works by, it makes your water molecules move. That's the principle of it. MRI is really good for diagnosis. It's because everything that goes wrong in your body, whether it's degeneration, whether it is tumour, whether it's trauma, it all creates edema. So edema is water. So that's why MRIs are so brilliant at diagnosing things, is because it looks for water in the wrong places, it makes your water molecules move. And that's why they're very sensitive. The problem is that area here could easily just come up as high signal. So sometimes the issue with the MRI is, yes, abnormal, but how abnormal? And therefore that's why sometimes we need to put fluid into the joint, so a contrast, to be able to distinguish between abnormal and tear. So that's a Bankart lesion. And so surgery-wise, these are people, if you see them in your clinic, they struggle. If they're young, instability, type 1 instability, if you're 18, the chances of you having ongoing instability in your shoulder has been reported up to almost 90%, 86% in one of the papers. If you dislocate or you get a Bankart lesion, then you're going to have problems with your shoulder for 86% if you are 18. But if you get this lesion when you are 35, the chances of having problems with it are about 17%. So we're in a different age group. So you can have instability within the shoulder, but something cracks. So in traumatic instability, what cracks, and also this is the same as type 2 instability, is we get stiffer. And also we hang up our rugby boots and we decide, actually it's probably not a great idea doing these really big serves. I'd probably, do a little bit more down here. So you evolve. So instability is a young person's problem. So you can see the changes on MRI in the older people. Often they don't have any problems because they got so stiff and they don't do contact sports. They don't get instability. Instability is a symptom. It's not a diagnosis on an MRI. People who are unstable, they don't like often to bring their arms up into this position here is the issue. And so in the young, we do something called an anatomical repair. And what that is a repair of a Bankart lesion. And so that labrum that's torn away from the socket, I pretty much freshen the socket and I put it back and I retense them. And that works really well. It's successful in about 80 to 85% of people who don't have ongoing instability. And so you can see arthroscopically here, we use these little, that's the probe showing the lesion here. Then what we do is we freshen this all up here. So everything in orthopedics is about, if you want anything to heal, it needs to bleed. So you scrape away the bone, and then what we do is we use these fancy tools. This is a needle and it passes sutures, and then that's the repair here of so we put a few repairs. So that's called an anatomical repair of a Bankart lesion. That's what we use for type 1 instability or traumatic instability. Non-anatomical, sometimes you can't get them stable, and you might have come across a condition. So if they're a really young guy and they're at the top of their game in rugby, if they're constantly dislocating, you may want to do a non-anatomical procedure. What that is called a latigué, or a Bristow latigué. Latigué was the French version. There was a Bristow, which was the English version. Unfortunately, the French blokes just, I don't know, the British guys has gone back, and but this is the common form now. And what that is we've actually, it's called a non-anatomical repair. So actually what we've done is you naturally have, so this bit of bone here is your coracoid, which should live there. So what we've done is we've taken the bone on your coracoid, we've chopped it, and we've transferred the bone to here. And so this, your coracoid, has your conjoint tendon on, and so we've taken it from up here to down there. You think, my God, that's madness. Surely, why on earth would you do that? Why does that work? And the reason why it works is because it creates something called a sling effect. So you can see here, do you remember I said about the hammock? Where the hammock was holding the ball. So what we've done is we recreate a hammock. So the biceps and the coracobrachialis tendon here acts as a hammock when the ball goes up into this position here. So type 2 instability, just say type 2 instability is 95% your game. Surgery for stretchy people, yes, we can do it, but it's the last gasp. It's a thing that we think, the reason is you can tighten stretchy people up. So you can, it's a little bit like a curtains. What we do, if you imagine that the curtains over there are their ligaments, what we do is we pull the curtains really tight. The problem is stretchy people just stretch out and they reform curtains. And that's why surgery for type 2 instability for stretchy people is something that is last gasp. So they come to physios, osteopaths to work the shoulder to be able to strengthen it, because, okay, your ligaments might not work, but the secondary stabilisers within your shoulder are your muscles. And those muscles need to be retrained to push the ball in the socket and to react. And the reason is they react because if you don't have your ligaments, what do your ligaments do? Well, your ligaments are check reins, so they tighten, and so when you're up in this position, your ligaments tighten, feed back to your head, and your head says, "Oh, I don't think I'm going to go any further, it's a bit too far." And your muscles contract. Whereas stretchy people, they don't have that. Their ligaments pull, and because they're quite lax, they don't fire until they're too far. And then when they found it too far, the muscles contract, and then that's why they become very apprehensive, and they then develop a vicious cycle. So a lot of the work that's done non-operatively is to recreate that proprioception and to build the muscles. So the muscles are constantly pushing the ball into the socket. So the next age group, well, again, this is an old slide. I think Kat Deely's now over 40. I'm going to have to change that one. So I'll have to try and come up with a younger version. But the young, 25 to 40, they classically get a really common, it's something called functional impingement. And what that is where they get impingement, but not in its true form. Now, impingement is very controversial. What causes it? What is it? Now, impingement is, so classically, in the 1970s when impingement was first coined, it was by a chap called Neer. And what he did was, he said, okay, everyone's ball is riding up. And it rides up, and also the space above the ball is getting too tight. And if we chop away some of that up at the top, there, if we chop away some of the subacromial space, that's perfect, that'll work. And what happened was, so that the operation of a subacromial decompression, which was open, was coined, and that's why we got subacromial decompression. And then a chap called Bigliani in the 80s, what he did was he did some work, and what he found was people who had a really tight, so if you guys probably remember your anatomy of, so your ball and socket, and above it you have your acromion, and everyone's acromion, and so Bigliani found that people can have a flat acromion, they can have a curved acromion, and they can have a hooked acromion. And people with a hooked acromion, lots of them had tears. And so therefore, everyone thought, well, if it's a hooked acromion and there's tears, clearly the hook is cutting into the tendon, and that's what's causing you to have a tear. And so everyone believed that making the space bigger sorts out your problem, and the hook was causing the space. The problem was then in the 1990s, what happened was a chap did histological assessment of the tendon, and what he found was people's tendon tears, if it was an abrasion, so if it was that the hook was scraping away and the tendon was failing, being scratched and attrition, then you'd expect the tendon tear to start on the top. And actually he found that the tendon tear started on the bottom. The majority of people with tendon tears had the attachment of the ball onto the socket. And so rather than it being scraped away here, it was kind of failing by being lifted off, and the tendon was failing. And so it wasn't a space issue, it was a tendon failing issue. So therefore that then made everyone think, well, crikey, God, but we've been doing this operation for so long, and we do it this way because, well, that's what we thought. So then, then people thought, well, why are the tendons failing? And it's then coined, initially it thought it was extrinsic, it was a space issue, and it was scratching away at the tendon on the top of the shoulder. But now there's a secondary, which is intrinsic, which is where the tendon starts to fail, and therefore you lose control of the ball in the socket. And so rather than the space being tightened, it's the fact that the ball isn't very well controlled, and it lifts up. And in young people, that's what they get. Because anatomically, nothing's changed. The ball, they just lose control of the ball. And so they get functional impingement where the ball rides up. As you get older, if you lose control of the tendon, what happens is that the acromion, everyone's acromion when they're born, starts flat. So the actual shape of your acromion when you're born is flat. And so it actually evolves, that the acromion starts to hook over time. And it hooks, we think, because of the stress on the ball, that the tendon starts to fail, and then you get calcification in the hook. And actually the hook is calcified ligament. And so it's that causes it to evolve. But young people don't get that. So doing subacromial decompressions in very young people, they haven't got an anatomical abnormality. It's that they've lost control of the ball. The ball's just moving around too much, and that's what functional impingement is. And again, who treats them? You guys treat them, because it's not an anatomical problem. It is a functional problem. If they retrain their tendons to work better to push the ball in the socket, they'll get better. And it's all about that training. Other things that come up in the young is ACJ pain, classically. Actually, I think I've got it on the next slide. So ACJ, instability we've talked about, and slap tears. I think I've got 3 more slides with a bit of explanation. Sticking with the functional impingement, I say, so it's that, the movement, there's too much movement in the socket and they lose control. And so, you know, how does your arm, you know, why does your arm move in the way it is? Why do we have a shoulder? Well, we have a shoulder, the reason why you have a shoulder is to put your hand everywhere in space. If you took your hand off, your shoulder would be useless. Your shoulder's there to put your hand everywhere in space. And so what happens is it means that the shoulder is naturally very unstable, because it's not like your hip joint's really deep, or your knee joint's relatively constrained. Your shoulder is a wall with a ball next to it. And so that ball has to be held into the socket. How is it held? It's held by your muscles. Your ligaments play a role at the end as check reins, but it's held by your muscles. And so functional impingement is where these people, they lose control, and so they move around too much. They lose control because they're scapular, they get the wrong posture, and we've got a real, you probably see much more than I do, but there's a real epidemic of people at work, on the computer. And the problem is they set their shoulders constantly forward. And so if you're constantly shedding your shoulder, so if you spend half an hour in this position and waggle your arms up and down, your arms hurt. And people do that hour after hour, 24, 48, week, 2 weeks, and then they present to you, God, it hurts, yeah. And they're used to this position. And so they've forgotten how to position the shoulders. Shoulders don't work like this. They work by being set back and moving up. So that posture and setting of the scapula is really important. And these are all the things that the young people get. And they can often have normal MRIs. So again, coming back to no internal derangement, but bloody hell, these people can't move at all. But they've got normal MRIs, they've got no internal derangement. It's because it's a dynamic problem. So I always compare shoulders to puppets. Puppets on a string, I often tell people, if you have a puppet on a string moving up and down, you pull one string and you will loosen another, you ain't going to work the puppet. So it's very same with the shoulder. Everything is based on that balance of muscles. So therefore that's why treatment is physio and steroid injections. Some people do need steroids because you can work on them, but they're shouting ow every time you move it, you're not going to get anywhere. ACJ pain is another thing that young people get, and what that is pain often at the top of the shoulder, on the finger. Where's the pain? You always point with one finger. Bra strap, pain there. It's classically people that do a lot of heavy weights, a lot of high arm work, and they point to the shoulder. You can get several issues with it. You can get arthritis. Arthritis of the ACJ is a really common diagnosis. If you x-ray everybody who was, I think all women over 80 will have arthritis of the ACJ. And I'd say, by the age of 50, probably 40–50% of people have it there. So it changes. It's really common in the asymptomatic population. So you need to make sure that's where the pain is, because it's so common in the asymptomatic population. You get osteolysis of the ACJ. Osteolysis is where they pretty much, that ACJ there, it was there, and now it's suddenly disappeared. And so that ACJ is just disappeared, and why does that happen? It's called osteolysis. The bone dissolves away, classically in weightlifters, and you can see it on an x-ray, and it's due to abnormal stresses. Another thing we can see is that's an x-ray showing the ACJ, acromioclavicular joint, with arthritis, but you can also dislocate. And you might see a lot of people with dislocations. The dislocation is quite controversial, because if you went to America, you get an operation. Everyone operates. Why don't you? But in the UK, we're much, much more conservative. Okay? So you might see a lot of ACJ dislocations in your practice. And what we generally do is the majority of them do well. So of all the dislocations I see, 95% of them I don't operate on. And generally now we wait. So I'd normally see them at the month stage to see where their symptoms are going. There are people that can get problems from ACJ dislocations, but it's a small number, and it's generally if they lose the ability to control it. So imagine if that's the ACJ, normally it goes like this. Sometimes it goes, that's kind of type 1, type 2, type 3, type 5, type 4, it kind of goes backwards. But it's generally if they lose AP instability, they get problems. And what we know is actually operating on them, you can operate on them late and you get the same outcome. And so generally we'll watch unless they're poking out of the skin. So certainly in our region we're relatively conservative with them, and we'll look. Now they can look awful, and so some people's their shoulders pretty much hang down, they get a big step. But you say to people, well, you know, you don't have surgery for cosmetic reasons. You'll be swapping a big step for a big scar. So that's ACJs. SLAP tears. SLAP tear stands for superior labral AP anterior posterior tear. And what your SLAP tear is a tear of the labrum, like before in the instability. We had a tear here. This is actually a tear up at the top where the biceps, your long head of biceps. Now your long head of biceps is something which is quite controversial. In the 1990s, the French would just chop everybody's bicep, long head of biceps. And it's a really common thing to do in surgery. Everyone's, oh, you know, French just chop it. But the long head of biceps is a little bit like your appendix. You don't actually need it for function because by bicep, two heads, you've got a second head, which works next to the conjoint tendon, which is part of the conjoint tendon, and that does the load. The only downside of cutting the biceps is that you can lose the contour of your biceps, but pain and function-wise, there's no downside. It's just that if you cut a bicep, then 3 out of 10 times they'll get the Popeye lesion, but 7 out of 10 times they don't. So there's also a lot of people out there in their 60s and 70s who've got ruptured the biceps and have the normal shape. So in young people, we often see SLAP tears. SLAP tears is classically a throwing injury. So if you see people and they're struggling with throwing a cricket ball in this position, it's the classic, because this was kind of diagnosed from America, where they do all the pitching, and they have huge forces, especially in young people. And so it's a throwing problem, generally, SLAP tears. If you're on an MRI, you see a SLAP tear in someone who's 50, it's probably not a SLAP tear, certainly probably asymptomatic. So it's a SLAP tear, it's a young person's problem, and it's generally in the young, and generally it's when they recreate that throwing action that they struggle. So we are 20 minutes in. Why don't we have 1 minute, 2 minute break? Because it is an hour and a half. Normally you'd have 2 speakers. So if you want to get refreshments, then we can keep on in the middle age. So unfortunately now we're moving into middle age. Now I need to push this back a little bit now. I've hit 40 as you know, you need to be 45 and have to be the cut off of middle age. So now we're more into the degenerate problems that we see, which is the tendinopathies and the rotator cuff tears. Calcific tendinitis, frozen shoulder, and early arthritis. So rotator cuff tears, they're relatively controversial because we see a lot in the asymptomatic population. So if you took somebody who was 65, then 25% of them will have tears in the tendon, and this is taking people off the street who've got no symptoms. And so the difficulty is knowing, you know, who are these people, and then suddenly they get pain. So what is an acute tear? So as a surgeon, I want to see acute tears. I want to see people, because if they've got an acute tear, then there's evidence that we should be fixing within 3 months. And what is an acute tear? That's really difficult for you, because you image them and you think, oh God, it's an acute tear. But it's a traumatic element, because the majority of the tears we see are acute on chronic. What that means is it's a chronic injury or a chronic tendinopathy, and it's just gradually given, and then it's torn and torn and torn, and suddenly they get symptoms. But there are acute tears, and they're often in the younger people where when the tendon is a good quality, and it was good, and then they did something, and now they cannot lift their arm, okay? And there's and they are where they've got an acute tear, where they've torn off good tendon. The reason why we want to see them quickly is because they're very repairable, and the difficulty they run is it can retract, and if it retracts, it can become irreparable. And the tendon, you know, the difficulty we have is, you know, some people will tear and the tendon will do nothing for years, and other people will rapidly go back, and they suddenly, unless I can get the tendon back onto bone, I can't repair it primarily. And so, you know, looking at, particularly the young age group, under 60, if you're in that and you're worried that it's an acute tear, then we should get imaging quickly. The aim will be for us to fix them within 3 months. Calcific tendonitis is it's a strange diagnosis. I don't know how many people you see with this. I suspect it's different. You might see someone and they are just in agony. And I don't know your population is. I know calcific tendonitis pitches up to A&E, and they pitch up to the GP, and they often mimic a septic joint, where the joint has become a septic joint being an infected joint. And if you ever see people out there in agony, they will not move it. It is extreme pain. So calcific tendonitis mimics that. It's a condition where calcium forms within the tendon, and it can have a pressure effect, and that pressure effect can cause extreme pain, and they just will not move it. They can't sleep on it. They'll be banging on your door, you know, every few days. I've often had to ring GPs to say, look, this is a condition, please give them more painkillers, because patients have rung my secretary complaining. So it's often it's pain, and it's diagnosed on an X-ray, and you find it doesn't project as well, but you get this big lump of calcium here. And the treatments for them, I'd give them a steroid. Steroids work really well to reduce their pain very quickly. It takes about a couple of days, but they generally, then they can get sleep at night. Other treatment options are we needle the calcium, so we use ultrasound to needle the calcium and break it up, or we use surgery, so we'll do a subacromial decompression and excise the calcium. So I'll find it with a needle and I'll excise it out, and that works very well for patients. Frozen shoulder is a condition, it's really common in diabetics. In fact, in a diabetic's lifetime, 30% of them will get a frozen shoulder. With diabetes rocketing in our population, in type 2 diabetes, we're seeing more and more frozen shoulder. It comes in 3 phases: pain and stiffness, and then stiffness. It mimics arthritis, and the only thing that can distinguish between osteoarthritis and a frozen shoulder is a plain X-ray, because classically they lose external rotation, and we'll show that in the examination. Treatment, generally, if you see people in lots of pain with a frozen shoulder, whether it's physio, osteopathy, there's not going to be much you can do for them. You're not going to be able to move them because they're in too much pain. And so in the first phase of a frozen shoulder, where they're getting pain and then the stiffness is coming, I don't recommend, you know, physical therapies. I just say, or because I see so many patients who, I went there for 2 months and it was agony, and they kept trying to stretch me out, and it didn't work, and it got worse. You can't beat it. It's not that these people are mimicking it. They cannot. When I see them in surgery, they are frozen. And what I do is I manipulate them, and I'll break the capsule, and I have to physically, and they go, and so it's a physical barrier, and it's not, you can't massage or manipulate that out when they're awake. So there's a real physical fix. And so with frozen shoulder, physio or osteopathy comes once the pain is settling. Okay, so in that first phase where they've got lots of pain, you can't turn it around. They will stiffen, and all you'll do is make their lives miserable trying to stretch them. So we leave them then, and then, so on a surgical point of view, we offer them something called an arthroscopic arthrolysis. It's very good. It works very quickly. So I can give someone a free range from an arm that doesn't move at all, and they work around like a robot. You can give them a full range of movements there and then. then it's just about keeping them going. So they'll have this much, your tapes are here, they'll lose a bit because it's stiffened, but generally, functionally, they work really well. But really, the take-home message for you guys is, you know, once they've had the operation, I get them all back to you to just work, keep it going, retrain the shoulder. But in the first stages, you're not going to beat it in a frozen shoulder. It will just keep freezing. In the old age, patients often get arthritis, cuff tear arthritis, massive cuff tears, and biceps ruptures. Osteoarthritis, what we see is patients, the classic is reduced rotation, night pain, so they get lots of night pain, they get crepitus, it crunches away as they move it. Treatments for osteoarthritis are steroid injections. There is arthroscopic surgery we can do, but it's 50-50 whether it'll give them a big benefit. Generally for arthritis, if the pain is coming from the biceps, I can snip the biceps. If there's loose bodies in the way, and so when you see patients with arthritis, the question is how much is it mechanical pain? Is it locking or is it blocking? Then arthroscopy can help, but if it's just a grind of, you know, loss of cartilage, arthroscopic surgery is going to make no difference. And the only thing that really will make a difference to some of these more extreme cases is surgery, replacement surgery, but there's risks. And so it's that balance, what you can live with. I always tell people, keep muscle bulk. You guys, you know, work hard, train people, help people with this, but keeping muscle bulk makes a big difference. We all see athletes where footballers, they go up to the end of their career, age 38, and you get an x-ray and their knee's shot to bits and they're still doing everything. 2 or 3 years later, whether you stop doing the sport, everything collapses and they get extreme pain because they lose muscle bulk. And so it's the same in all our joints, muscle bulk is essential. Just going over quickly replacements. There are a couple of different forms of replacement. This is called an anatomical replacement. And you can see, that's the ball, the socket's over here, and I've replaced the ball with the ball and a socket with the socket. With this type of replacement, you need a tendon round it, because if you don't, the ball rides up and they're very loose. This was a big problem. Initially, we used to do something called copeland resurfacing, which you might have seen in your patients if you've been working long enough. That was all we did in the kind of the 1990s and the early noughties. Everyone got one of those. And the problem with them was they went in and everyone was happy, and then year on year they got worse. And so it's just because metal doesn't work really well next to cartilage, and they just wear down and the pain comes back. So that's why total shoulder replacements are really replaced, resurfacing. Total shoulders, anatomical like this, ball for ball, socket for socket. You need a tendon, otherwise it moves around. Problem with the tendon is as you get older, you get tendon tears. And the tendon, if it ruptures, you can't put one of these in. So patients can get cuff tear arthropathy, and if we lose a tendon, we do one of these fancy operations. And you can see here, what's happened is the ball has been replaced with the socket, and the socket has been replaced with the ball. And the benefit of them is you don't need a rotator cuff tendon. And so these these now are the most common shoulder replacements in the world. And the reason for them is is because you don't need a rotator cuff. So you can have it for trauma, where the tendon may have ruptured, or you can do it for people with cuff tear arthropathy, which is where you've got arthritis, but the tendon's gone, the ball's ridden up, and they saucerize up here. So what they do is the acromion is like this, and because the head's rubbing against it, it saucerizes it. Massive cuff tears. As people get older, they can get massive cuff tears, and these are often people where they can't lift their arm at all. Reduce the range of movement pain. When you see it in the extreme, you might see in people in their late 70s, 80s, the ball goes forward and it almost bulges out here. And so because they have what we call escape of the humerus, and so it goes beyond the socket and it's touching the acromion, but also goes forward and leans against the coracoacromial ligament that gives way. These patients often get biceps pain, and so the treatment for massive cuff tears, steroid physio. People do have massive cuff tears, who have no symptoms. There was a guy when I was in Oxford, and he was weightlifting, and he had nothing on top of that. You say, how can that happen? It's because you can retrain the deltoid. And there's something called the Torbay technique, which is a physio protocol, which is for massive cuff tears. What it does is it retrains the anterior deltoid to act as, because ultimately what you want is something to push the ball down while it lifts the arm. Because your deltoid attaches here, it levers the ball, and what should happen is this, but without a tendon, is that all that happens is the ball rides up when the deltoid activates. And so, the way we treat this, steroid physio, osteopathy, repair the tendon primarily if we can, but a lot of people's tendons, they're not repairable. And so now we are moving on, technology is moving on. And so people are demanding more. You probably see that in your practice. You know, I'm 75, 80, I've got a big tear, but why can't I play tennis? Why can't I, go playing roller hockey? And you think, gee whiz, 10 years ago, you'd never dream of asking this. But now the expectation is people keep going. They're going to live that long, and they're going to have the quality of life that they want at that age. And that's brilliant. But that's where it's our problem. Because managing their expectations is huge. And so we try to repair the tendon if we can. But if we can't repair the tendon, we need to stop the tendon, the ball riding up. And so what we do is we use augments, so we can we can't get the tendon back on the bone. What we do is we put a patch over it to and then stitch the patch in. In some people, we can't even get a patch, and we use something called a balloon. And you might have come across, there's some patients out there now that are having this thing called a balloon arthroplasty. What the balloon is, it's up here. And what it does is, it's a balloon that sits between the acromion and the humeral head. And what it does is, it pushes the ball down. So what you want, ideally, is, while your deltoid's working, is something pushing the ball down. And so it's called a balloon arthroplasty. The balloon only stays inflated for about 3 to 4 months. So it's an adjunct to treatment. So it's not going to stay there for life. And what we believe is that if you give the deltoid an advantage and you rehab these people, you can then start to regain control of the head. And so it's an adjunct. So I put the balloon in, and then we send them back to you guys for the treatment, for the strengthening, for the range of movements. Other people, we can use patches. So there's several things on the market now that, around the country, people are using different combinations in different people. The balloon works really well in the elderly, over 75s. I wouldn't put it into a manual worker age 60. I'd be looking more as a patch. In the very old, sometimes you can't do anything other than a reverse total shoulder. So in some people, if they just can't lift and they've got poor muscle, they're really unhappy, then you can utilise a reverse total shoulder for massive cuff tears. Fran, we're on. So I was going to quickly, coming too close to the end, I was quickly going to do the examination technique and just quickly have a word, talk about imaging. Oh my goodness. Well done. If you're listening, Fran's shoulder does crunch.
It does, yes.
You need a microphone for that. Which one should we do? I don't mind. Which one we?
They're both bad.
Are they? Well, some of these guys, honestly, you've got a whole audience of stand up. Okay. So when I examined the shoulder, and initially, obviously, what's the first thing? As soon as she walked out, I looked at her age. I said, oh, obviously, young 30s. So, first thing you want to do is you look for any wasting around the shoulder. So, if you swing around, so obviously I can keep going around. So obviously around here, your infraspinatus, fossa, supraspinatus, it's very classic that they can get some wasting in these areas if they've got significant atrophy from tears. Look at their ACJ, have they dislocated it, it will sit up and the shoulder will fall. If you're worried about dislocations, you look at the contour of the shoulder, and you get a nice contour in normality, but in dislocations it falls off, so there's a real edge, because the ball's like this, so you get a very prominent edge, and so that's how you diagnose an acute dislocation. So the first, so shape, look at scars, palpation of the shoulder, diagnostically, doesn't give you a huge amount. There's 2 or 3 areas, if you swing around. So obviously the ACJ, putting your finger on the ACJ and saying, is this where the pain is? Pressing on it, palpation, that's very important. People localise it, it's bra strap, pain there. You can palpate along the cuff. Again, that can be useful, but it's not always useful. Certainly if it's calcium, they will be tender. You can palpate along the bicipital groove at the front. Okay? And again, generally, I put my hand up whilst doing a provocative movement and say, is the pain here? And obviously fractures and things acutely. So first thing I want to do is range of movements. You know, is she stiff? So what we do is, how high can you go? So you go all the way up to the top, bring it down, and then all the way up to the top. And so so forward flexion, and then mid arc, and then what? Are they recreating their pain in the mid arc here, or are they recreating their pain in the high arc? Mid arc is impingement or rotator cuff. High arc is classically ACJ. And if they get pain, you turn around this way so I can see your face. So, and then up to there. So, and then the other movement is rotation. So, how far they can rotate. So, have they got a full range of movements? In external rotation, there are 3 things that will block your external rotation: frozen shoulder, arthritis, or a lot posterior dislocation. Lot posterior dislocation is rare, but someone might pop in and suddenly you can't move it. Oh, you had a fall 6 weeks ago, and you do see them. I see about 2 a year of that pathology, and they've got no rotation. So that's firstly, you want to know, are they stiff? If they're stiff, they're frozen shoulder arthritis. The only way distinguishing is with a plain X-ray. Then you want to move to power testing. We test the power, supraspinatus, thumb down, hold that position, hold that, keep it there, keep it there, keep it there, stop pressing it down. I always find that telling people to hold a position is easier than say, push up against me. So hold a position, tell them to keep it there, thumb down. It's in the scapular plane, so that's about 30 degrees. That tests supraspinatus in the low area. Then put your elbow in, bring it into that position, hold that position, stop me pushing you in. So that's testing infraspinatus. Okay, so pushing. You can do the horn blowers, but for us, which is testing up at the top, so as you bring it up and you get them to push against in a kind of a horn blowing. Can I just bend it and bring it there? Yeah, push against me. And that test is meant to be teres minor and infraspinatus. The reason why it's meant to be more teres minor, the reason why it's less important for us as surgeons is because teres minor pathology is really rare, and generally you're looking at a cuff tear, and so if you're testing power and teres minor, if infra's gone, you know, it's a massive cuff tear. It's rare to get that pathology. So and then subscapularis, again, bring the hand around the back, hold it off your bottom, hold that position, and stop me pressing you down. Okay, and hold that position. And you test it against the other side if you're concerned. That, you know, obviously the dominant side should be slightly stronger, so that can often be a clear cue. Sometimes it's very difficult. You know, supraspinatus can, you know, deltoid will help it, and so it's very difficult to isolate it. So if you've got someone that's very strong, you'll find that, you know, very muscular, you're not going to notice a difference sometimes. So that's power testing. Then you move on to special tests. And so, okay, special test for ACJ would be scarf test. So again, it's bending your elbow and bringing it across the body, and you bring it all the way over here. And then a lot of people will say, oh yeah, that hurts. But it's where it hurts that's important. It's meant to hurt at the ACJ. So you say, does it hurt there? Because a lot of people, if they have impingement, will get pain here. So that's scarf test. Bring it back and relax. Then we have impingement tests, which are, I use Hawkins. And so it's scapular plane, bend the elbow, thumb down, and then rotate the arm and bring it across their body. I won't make it too far front. And so you're rotating. The reason why that works is because the ball isn't completely round. It's got a kind of a lumpy bit, which is a greater tuberosity. So by internally rotating, you're bringing that lump, the tubercle, forward, and it goes underneath the acromion, so you're making the space tighter. So, thought you were just practicing. And so that's why, so a lot of the impingement tests are that rotation down, thumb down. Some people use the, can up, can down. The reason why it's can down is because that brings the tubercle forward, tightens the space of holding that position. But Hawkins works well. Other tests are speeds, which is again like a bowling ball. Hold that position, stop it pressing you down. Do they get pain and resist it? Do they get pain in the groove? You can use Jurgensen's, which is again bend the elbow, hold the hand, and ask them to mimic rotating a screwdriver. Okay, and you resist that, and again they should feel pain here. If they're young, you'd want to do instability testing. The way majority of people have anterior apprehension, so you put your hand, usually you need a height advantage, which we have over here. And we bring the arm into this, we bend the elbow, and what you want to do is hold the shoulder forward. And what you're trying to do is you're controlling the ball. And as they come up into this position, you keep looking at them and say, are you okay? You okay? Not too bad. And then what they get is they get apprehensive. So they start to worry. And you say, do you mind going any further? And they'll say, oh, no. And then what you do is you bring the arm down, and then you hold and you push the ball backwards, okay? And you squeeze at the front. And what you're doing is, normally the ball's wanting to roll forward. By squeezing at the front, you're holding the ball in, bring them back into that position, and this is called a relocation test. And they should go further, and that'll be a lot more comfortable for them to go to it. So that's anterior apprehension and relocation. Posterior apprehension is you bring the arm forward, bend the elbow, bring it across, put your hand behind the scapula and push backwards, which can be and what you're trying to do is push the ball backwards and see if they're getting out of one. So imaging, so we've got plain X-ray. Just quick, with plain X-ray is brilliant as a screening tool. It's almost essential as a screening tool. If you are treating somebody longer term, what will a plain X-ray give you? It gives you lots of information. I see more and more people having an ultrasound now and not getting a plain X-ray. And in some ways you're opening yourself up to big problems with that, because ultrasound does not look at bone. And you'll occasionally come across bone tumours, and an ultrasound will come back as negative. And that ultimately, what you're trying to do is rule out. If you're treating people non-operatively, you're ruling out the nasty. And so it's understanding that if you're going to get an ultrasound, it goes with a plain X-ray, or you get an MRI. So plain X-ray and ultrasound go together. MRI can be on it, because MRI looks at bone and soft tissue. But getting a plain X-ray is really valuable. There's so much that can be seen on a plain X-ray. It'll rule out tumour, but it doesn't rule it out, but it's certainly a screening tool for that. It will tell you whether there's evidence of calcific tendinitis, arthritis. It's amazing how many people I've seen where they have lots of treatment and they come in, the ultrasound shows I've got a partial thickness tear, and they've got no rotation and they're about 70, and I say, have you ever had an X-ray? And you get an X-ray and they're riddled with arthritis. And I could have told them they didn't need any expensive imaging, they just needed a plain X-ray. So I'd really use plain X-ray. It's a very good tool. But if you're going ultrasound, ultrasound on its own is not enough. You must get a plain X-ray. If you're investigating people, you have to cover all options. And we see that in the British Shoulder and Elbow Society. We're getting reports of people where they've been missed because they have an ultrasound. Ultrasound will get it right maybe 70–80% of the time. It misses things, and you just need to understand the test that you're requesting. Quickly, what not to miss. So, post-op prosthetic infection. So if you're seeing people who have had a knee replacement, hip replacement, shoulder replacement in the early days, and they look like they've got an infection, we want to see them back. The reason is because if you have an infection and we catch it early enough, then we can save the prosthesis. If you go beyond a month, the infection, if it's a deep infection, creates a biofilm. That biofilm, antibiotics, will not penetrate. And so you are then sanctioning that patient will have a 2-stage revision, which is miserable. We take the implant out, they have 6 to 8 weeks of antibiotics. If we can get them early enough, so in that period, in that first few weeks, of after a replacement. If you're fearful that they've got an infection, it should be investigated. Compressive neuropathy, so carpal tunnels, symptoms come and go. So it's great, if you're treating somebody and their symptoms come and go, you're safe. Once they get permanent symptoms, that means the nerve has become damaged. As soon as a nerve is damaged, the difficulty is you can have surgery for carpal tunnel, on the nerve, but then it's a watch and wait. You can take the pressure off the nerve, but the nerve's damaged, it may never recover. And so it's better to get to these people when they have intermittent symptoms. When, I'm not saying if they get it once a week, but as soon as people start getting symptoms where they are, it's intrusive, it's happening during the day and night, you get into a stage where the nerve is becoming compromised. And so we want to see the patients, if they're going to have surgery, that's when to have it, that's the window. We often see people late, and then it's well, you should have come earlier. Why didn't you come earlier? Well, someone said it's only carpal tunnel, it's only on the nerve. The difficulty is once the nerve's damaged, we can't, you can have surgery, but you need to but I can take the pressure off the nerve has to recover. If you're if you're older, if you're 16, chances are it will. When you get older, the chances are it may not. Traumatic cuff ties, I've talked about. Tumours. I suspect everyone in the room who treats non-operative people, the thing you fear the most is being told that you've been looking after someone for a year and it's ended up being a tumour. And, that is the fear in non-operative treatment. So, we just need to get better at picking these people out. Unrelenting pain, where you just don't know what the diagnosis is. I've had a couple recently where, they really shocked me. I don't think we're going to get quite to the case reports, but I saw a guy recently, just a pins and needles, a bit of neck pain. And he'd been treated non-operatively for 2.5 years. And it just didn't all make sense. And I thought initially he had carpal tunnel, but in fact, he ended up having a benign spinal tumour. And, I was really surprised, but these things are out there. And it's just, we need a way of trying to pick them out. Sometimes imaging is all you can do, and sometimes it is just a suspicion. Someone just doesn't quite fit. Their pain is too relentless, it's not getting better, they don't fit that box. You have to think outside the box because they are out there, and unfortunately these are the patients that will sue you. And so it's just finding that way, and that's where imaging, that's why with the shoulder, just getting the GP to do a plain x-ray will often cover so many, it looks at sarcoma, or MET, which is our fear. What to refer early? Distal biceps ruptures. If someone has a distal bicep, we're not talking long head, we're talking distal. Distal is not a bicep, there's only one head, and it attaches there. So if it ruptures, we need to get to them quickly. You can do surgery late, but it's miserable. So distal biceps ruptures, we see them acutely. We like to operate them within 3 weeks. Fracture and dislocations. I don't know how many people would pitch up to your practices with a fracture or dislocation. Again, there's just too many variables. We need to see them in the fracture clinic. Yes, we treat the majority of people non-operatively, but we have a significant who do. Picking them out is the key of knowing when it heals, who's going to heal in the wrong position, who's going to function badly. In the upper limb, generally hands, there's a lot of function and problems we can get if it heals in the wrong position. So passing them through the fracture clinic. We run something called a virtual fracture clinic at Tunbridge Wells. So everyone that comes to A&E, we sit there and we see 80 people working our way through each of them. So we give a lot of advice. Unknown masses, and if you haven't got a clue. So that's where my role comes in. If you haven't got a clue, or it's unknown masses, and I see them, and stuff that I see, I think, I don't know. And we've got there's something called a tumour board, which is up at Stanmore Hospital, and we send up imaging that we're not sure about, and they provide us a really brilliant service. But they're the things that we need to be seeing early. This is what I'm going to send you on the. This is a flow chart, and it is. You may have seen it before. The CCGs for the GPs are now utilising this flowchart, and it's in this paper that Fran will send you. It's got about red flags, but it's pretty self-explanatory. But follow that, you'll do fine. It pretty much summarises examination. And then finally, thank you to Fran. I work, as I say, in the NHS, but also I do private practice through the SPA in Tunbridge Wells, and I also see patients in the field. So, thank you very much. And I reckon if this happens, we can all put up our feet over this summer, because I don't know if you guys, people's pains and sorrows go away in the when the happiness comes in. So if we win the World Cup, I reckon our workload will decrease, certainly till winter. So we'll get a lot happier.
We did have a question.
Oh, yeah, sorry.
Actually.
Go for it.
With the adhesive capsulitis, at what point would you then operate?
Okay, so I see people, how I'd normally see them, I see them in the pain stage, give them some steroid. As soon as the pain is starting to turn, I will offer them an arthrolysis. So I would then look to free the shoulder, and then I send them back to you guys to rehab them and keep the movement going.
About 6 months in.
Yeah, well, it's not an absolute, because the natural history of a frozen shoulder, it will get better, but it can take up to 3 years. And so it's that, and knowing who those patients are. And so the timing, people go through the phases very differently. Some people, the third phase is going to last for a long, long time. Some people go through the first phase very quickly, you don't even know it's a frozen shoulder, all you get is the pain. So it's based on, I generally go by the rule that as soon as they start turning the corner and the stiffness is there and the pain's starting to recede, then they'd be a candidate for surgery, if necessary.
The reverse shoulder replacement, you said, is most prevalent in the older population. Is it ever used in much younger patients if their presentation is through gross trauma?
Yeah. So,
And if it is, then if that person is quite young and fit and able, what is the genuine expectation of range of movement after that shoulder replacement?
It's tricky. Generally, we'll avoid putting reverse total shoulders into young people. That's my practice. The reason is we don't know the long-term outcome, and you burn a lot of bridges. So if you were young, if you were under 60, I would generally put in a half a shoulder replacement for trauma and stitch back all the tuberous, all the bone to it. The problem with those is they generally have two outcomes. One really good and one really not great, and it comes down to whether those bits of bone heal back onto the humerus side. So generally we don't put them into young people. Sometimes if they've had a half replacement and there's no other option, yes, we can do. And the youngest reverse I've done is in a 30-year-old rheumatoid, and there was just no other option. But you are burning bridges, and so it's difficult to say how well they'll do. It's if they're young and they're getting a reverse, generally they're in somebody that there's no other option, because it wouldn't be my primary. Fixation is in the young is by far my primary goal. Hemi would be the second. Reverse, I generally wouldn't do as a primary in a young because
is it very solid? Is it very solid?
Is it solid? It is, if it works well, it all heals, it will be solid. My expectation is it'll be able to get back to, many sports, but if they're young, they haven't got any further option. So I wouldn't be saying they're doing any impact sport or anything where it's a balance. So one of the reasons why we don't put them young is because they generally work them hard. And the problem with the reverse is there aren't many options, and revision surgery for those is highly challenging, high complication rate, and the outcomes are poor. And so generally you want to do, shoulders now is evolved into a kind of almost a stepping stone of knowing what your next option is. So you do this, knowing that'll give them maybe 10, 15 years to do that next. So it's hard to say, but I would, if they're very young, my expectations would be to hold them back, generally. But the expectation is they should achieve, that kind of range in that area. But everyone's slightly different.
Yeah.
It's a difficult situation in the young.
All right. Thank you.
What's your general perception on accelerating rehab protocols?
I suppose it depends what the diagnosis is, and it depends on what the treatment is. So in fracture, I'm relatively for it, because we know that as surgeons, we hold people back. Why? Because we fear about fixation. But the actual reality is, and the evidence shows that people do better when they get moving. But we as surgeons are often hammered by, all it takes is one silly idiot who's done this and saying, why'd you do that? We had a woman about 4 months ago who had an X-fix on her arm, and she tied the dog's lead to the X-fix and was walking the dog with, and you can imagine what happened. Horror. And so that's why we are kind of a slightly, God, don't let the patient do anything until it's all healed. But you're absolutely right. I'm a fan of it. I think tendons and cartilage need movement. We know that so I'm a fan. But I think we also need to think about where the end goal is, in the sense that for some people, the expectation of where they're going to get to isn't that great. And so and there may not be any other options for them. And so in a 75, 80-year-old with a proximal humerus fracture, fixation, the bone in great, and the options, if it all goes wrong, are pretty horrendous. So everything's a balance. It's pick your complications, pick your risks, fight, but it's, very much patient related. And nobody, everything should be bespoke. We shouldn't be following absolutes because everyone's different. And we know that there's some people that need to be reined in, and we know that there's some people that need to be pushed ahead. And so everything has to be a bit bespoke. Anyone else? Good. Thank you very much. Thanks for coming. Pleasure.